starting right from the basics, first thing that we all need to know is patient positioning. Then what do we need? How do we need to start? That is the basics of shoulder arthroscopy. We'll
Siddharth, just a minute, just a minute.
yeah, sir.
All participants, please note that if you have any questions, you can write on the Q&A box, and we will try to address all your question and answers just after the talk. So if you have any queries, any questions, you can write on the Q&A box. Siddharth, please continue.
Yep. Considering that this is a beginner's basically course for shoulder arthroscopy, I'll keep it right at the basic level so that we can use it as a platform to start our scopy. So, yeah. First thing is position, beach chair or lateral position. It's always a confusion for the young arthroscopy surgeon to where to start. Beach chair is a very good position. The basic disadvantage that I have in beach chair is a proper instrument or a setup you need is a patient in beach chair. Rest all the things at anesthesia point of view or the patient age, other things can be managed. The first thing that you need is a specialized setup. In case you have a specialized setup, then you discuss whether you need a beach chair or a lateral position. The advantage of lateral position, it's easily available, and it is easier if you are planning a subacromial pathology. It's easier to start with it. This is the basic advantage of lateral position. And a beach chair essentially is advantageous in respect that if you need to convert it to an open procedure, so it gives you a very good position in an anatomical position so that you can anytime convert it to an open position. For positioning, there's one basic tip that the patient, especially in lateral position, should be rotated 30-degree backwards, because we have to understand that the glenoid is in retroversion. So in order to get the glenoid surface parallel to the ground, you need to tilt the patient 30-degree backwards. Otherwise, throughout this surgery, you will be struggling with the inclination of the glenoid. So make sure that the patient is 30-degree backward and he is secured firmly. Otherwise, during the surgery, the patient may tilt more backwards, and that creates a lot of problem. Preferably, the anesthetist is using an extendable main circuit and is away from your field, and you're able to stand right over the head of the patient. Lastly, the traction weight, it should be average 2 to 4 kgs, and never use a cotton bandage roll to make a cord. Always use a nylon rope, because when you use a cotton bandage rope, it always loses most of the traction at the pulley itself. So use a nylon rope so that it slides. A tip for arm positioning: for glenohumeral pathologies, you need around 45-degree abduction and 15-degree forward flexion. For subacromial pathologies, the abduction required is minimal, that is 15 to 25 degree, and neutral flexion. So if you're doing in a lateral position, I would suggest you can tie a IV stand at the contralateral foot end of the patient for glenohumeral pathologies, and for subacromial on the same side. This helps in controlling the forward flexion. The disadvantage of lateral decubitus is essentially that if you want to convert it to an open procedure, it relatively becomes more difficult because of a non-anatomical placement. Portals. Now the portals, the basic for making any portal is a good surface marking. If you have not spent adequate time marking the skin properly, you will have struggle throughout your surgery. There are few landmarks you should be able to identify accurately. First is coracoid. You have to know where a coracoid is. You mark your coracoid wrong and you are through with your surgery. Second is anterolateral corner of acromion. And third is the posterior lateral corner. These 3 points need to be absolutely accurate. Sometimes in a bulky or a heavy patient, you struggle. Spend time before you paint or drape. Make sure that you are able to palpate these points after making position before you paint drape, because after painting, draping with betadine and everything, sometimes you struggle. If you want, you can even use a permanent marker to mark the skin before painting draping, so that you are more comfortable in your surface marking. Never skip it, and always do it, and do it yourself. Then after you are done, marker coracoid, mark anterolateral angle of the clavicle and the AC joint. After you are through with the marking, then draw a bursal orientation line. This is basically from the posterior edge of the AC joint, draw a horizontal line perpendicular over the arm of the patient. Essentially, it divides the AC joint acromion into the anterior 40% and posterior 60%. On this line, if you go laterally, 5 centimeters from the lateral border of acromion is the approximate position of your axillary nerve. So in beginning stages, what you can do, you can take a skin suture, maybe athlon, and just tag it just around there, so that you are sure that this is my distal limit. Just 1 centimeter proximal you can tag. So anything what may have happen, you don't cross that 5 centimeter area. Even if you convert it to open or anything, you just put a skin suture to limit yourself in initial part. Secondly, always anticipate the pathology. You should be clear. You should have a plan in mind before you go in, whether it's a glenohumeral or it's subacromial, what it's primarily. Sometimes initial stage you say ki subacromial decompression kar denge and we'll see inside what it is. Have a clear plan in your mind. Don't go random. So this is a surface marking. We have marked, I'll just use it. This is the anterolateral of the. This is essentially your coracoid. Where is the coracoid? I think I have not put the view properly. Here I have marked the coracoid. This is the anterolateral angle of the acromion. This is the line joining the coracoid and the acromion. This is your posterolateral acromion. So these 3 points, 1, 2, and 3, need to be sure. Now coming on to your portals, standard posterior portal, the first portal that you make. The posterior lateral corner of the acromion, it is 1 centimeter inferior, 1 to 2 centimeter inferior, and 1 centimeter medial to that acromion. You can say it's a soft spot, that is, and you make an incision, direct your trocar and cannula towards the coracoid and go straight towards it. You will more often than not straight away enter the joint in the initial stages. Later on it becomes easier, but initially you tend to miss on the joint when you try to enter. So direct your tip of the is the best way, and just modify this portal according to your pathology. If you are planning a subacromial procedure, you can keep it less inferior. It's a glenohumeral procedure. You can keep it like 2 centimeters inferior from the posterior lateral acromion. So main usage that you have is visualization and labral repairs and posterior dislocations and posterior base cuff tears. Basic first thing is visualization. Second are the anterior portals. We have mainly 2 anterior portals, and they are essentially all located between the tip of acromion and the coracoid. So one thing you have to remember is that you have to stay lateral to coracoid. Just stay lateral, whatever may happen, stay lateral to coracoid in all the anterior work, because all the neurovascular structures are medial to coracoid. Secondly, avoid abducting the arm more than 45 degrees. That places axillary nerve more at risk. And always place the portal superior to subscap tendon inside while viewing inside the joint. Otherwise, you end up struggling inside the joint with the subscap getting in between your portals. So the first is the anterior superior portal. We have 2 ways of making it. And you can make it inside out, or you can make it outside in. Inside out is that you take your trocar and you make your point inside and put it and put a finger rod into that trocar towards the direction. That is the inside out approach. Initially, if you are struggling to get it from outside, inside out approach is good, but ultimately, in the long run, the standard approach is outside in. You take an outside reference point like 1 centimeter lateral to the anterolateral tip of acromion, and you try to enter with a spinal needle. The superior portal try to stay close to glenoid. That is, be more medial. And in slap repairs, you should use a 8 mm cannula, and Bankart repair uses 5.5 or 6.5 mm cannula. I'll tell you why. In Bankart, you use this portal to look at your labrum while you're doing this. So use a smaller cannula in which your trocar goes, so that you can use it for visualization initially and later on for suture management. The main usage is for suture management in most of the Bankart cases, and you can use it for visualization while you are preparing your labrum in case of Bankart. For slap repair, this is the main working portal. Then the anterior-inferior portal. This is the main working portal in the anterior aspect, especially in the Bankart. You place your anchors through this, you take your bites through this. So this is the main working portal. This has to be right, just superior to the subscap and as lateral as possible. Why lateral? So that you have a good angle for anchor placement and a good angle for taking a suture lasso. Otherwise, if you are close to glenoid, you won't have a good angle for the anchor placement, and your anchors will tend to slip off the glenoid surface. So externally, it is 1.1 centimeters inferior and 1.2 centimeters lateral to the coracoid. I always palpate the skin from external surface and see the dimpling coming inside, and then put my spinal needle. That is the tip I would give, rather than calculating these distances. That you press your skin from outside and try to figure out which is the most prominent point where you want to get the portal inside. That is the best way to mark your portals externally, especially interior portals. And for Bankart, this is essentially used for labrum, anchor placement and suture passage. And sometimes you can use it for visualization in case you're doing a posterior labral work. Then you use this portal for visualization also. The lateral portals, you can make it 3 to 4 centimeter lateral to the lateral margin in a lateral margin of the acromion, in line with the bursal orientation line that we made earlier. It can be shifted anterior or posterior depending upon the tear location. If you feel that posterior, the tear is relatively posterior, the rotator cuff tear, so you can shift it posterior. You essentially need it in rotator cuff work. You don't need it really in your Bankart work. And the thing is that it can be extended, as I told, to mini open technique in case you need to. So mark your 5 centimeter point that you have a distal limit. Uses is that is essentially used for rotator cuff preparation, suture passage, even anchor placement. Risk is the axillary nerve. Other lateral portals that you have an option is anterior lateral, posterior lateral ports, or depending upon the exact location of the cuff, your required direction, your required trajectory, you can make n number of portals in this region by a spinal needle. So you can just anterior, posterior to this anterior lateral. Now, basic portals are covered up. Now we have a few more portals like Navasier and all that. I would suggest you to stick to these portals initially in a few surgeries, and then stick to more, then go over to more portals, because the more you know, the more chances that you will get confused in initial cases. Then comes the diagnostic round. So thing is that almost all structures can be visualized by the posterior portal. That is what you need to know, except for the first thing when you enter the shoulder, you need to see is biceps. And there's a tip in this: when you enter the shoulder, put in your trocar cannula, put in your scope inside. Do not switch on the fluid. Do not switch it on. Try to search for the biceps tendon or the bone or something like that before you start the fluid, because if you are the extracapsular area and you start the fluid, invariably you will start collapsing the joint. So better is identify something in the joint and then turn on the fluid. So generally, when you see the first identifiable structure is either the bone of glenoid or the humerus, or the logical structure is biceps tendon. You will see a consistently linear structure extending from the biceps, from the glenoid, running upwards. Once you are through with you have identified biceps, so you are more or less sure that you are inside the joint and you are at right place. And as soon as you enter the see the biceps, you see this triangular area. This is what you call the rotator interval. This is a triangle formed by glenoid inferiorly, biceps superiorly, and this is subscap, which makes the inferior boundary. Here is the place in which you will have both your portals. This is the anterior superior portal. Here somewhere you will have your anterior inferior portal. So this is the main part. Check first, you see when you look at the biceps, after diagnostic round, then you look for the pathologies, because you have not yet made any of the anterior portals when you start the diagnostic round. So just look at the pathologies once. Anterior triangle, as I told you, is the triangle rotator interval formed by these three structures. Now the subscap, you can see the subscap right here, and you can probe it for the tears. SGHL. SGHL is an inconsistent structure as far as visualization is concerned. It's a very flimsy structure. You can see it somewhere close to the biceps fully. Sometimes you're able to visualize it. Most of the times you're not able to. So it basically acts as a sling for the biceps tendon. Now the subscap recess. This is a recess which is behind this is MGHL. You see the subscap, there'll be a structure which is crossing perpendicular to the subscap, or maybe at an oblique angle. This is MGHL, middle glenohumeral ligament. And you can see it very prominently in frozen shoulders. You'll see it as thick as a band you can, and you may even confuse it for a thickened subscap basically. So behind the MGHL and anterior to the subscap is a recess in which sometimes loose bodies can lodge, and you can once inspect it later on before you close the things. MGHL, as I told, this is subscap, this is a glenoid, and MGHL is a perpendicular running band. This is reasonably normal looking MGHL. In frozen shoulder, you see such a thick MGHL that you actually get doubtful whether it is a subscap or a MGHL and you should cut it or not. So be orient yourself MGHL on a regular basis so that you don't get it confused with the subscap. I remember my first frozen shoulder, I was really worried while cutting MGHL whether it's I'm not cutting a subscap. So sometimes it is absent and seen a cord. Sometimes you have a Buford complex. That is not a very common entity, but essentially you always see MGHL perpendicular to subscap. Now coming to the labrum. While you have seen the rotator interval, now you see for the glenoid and the labrum. I'll cover it later. Now basically you withdraw your scope a bit and look at the glenoid articular surface. You sometimes see an area of pale cartilage right in the center of the glenoid, what you call the bare spot. So it is essentially the center of the glenoid, and you expect equal amount of bone anterior and posterior to this bare spot. So this can be used as a rough guide to estimate the bone loss in case of glenoid deficiencies and recurrent dislocations. Also look for mid-glenoid notch, sometimes seen as a small depression at the edge of the labrum, which separates the anterior labrum into two parts. You may or may not find it. You can look for it. Then just anterior to, you can say lateral to the glenoid is the humerus head, and just have a look at the humerus head cartilage and try to pass your scope between the humerus head and the glenoid towards the inferior glenoid. If it is easily passable, that is a positive drive-through sign, which indicates basically laxity, or excessive tightness may actually indicate a frozen shoulder or too much of adhesions, which is not allowing you to go in between the glenoid and the humerus. So you should be able to pass it with a mild effort. If it is very easy, it is lax. If it is too tight, it is basically a frozen or a adhesions. Now going in the inferior part of glenoid, you find the anterior inferior glenohumeral ligament and the anterior inferior labrum. This is the area which is the area of pathology in case of recurrent dislocation of the shoulders, and you have to look for Hagel lesions there, and also the damage to the anterior inferior glenoid labrum. And while you have, I'll come to the video and I'll show you all these structures right now. This is the glenohumeral arthroscopy. How will it work? Yeah. So this is the glenoid labrum. As we can see it, well fixed labrum going right down. This is the inferior part of the labrum, and this is the basically we have gone inferior to the glenoid. This is the biceps tendon. We have made the anterior superior portal there. The biceps tendon and the anchor of the biceps. Here we check for the slap lesions. check for the integrity of the labrum once, especially in cases of recurrent dislocation of the shoulder. So you see there is the cartilage. It's difficult to appreciate here. There is a, it's trying to show the bare spot.
And Dr. Siddharth, there is a
Yep.
question from Dr. Sandeep Saraf that how will you differentiate between MGHL and the subscap?
So basically, you rotate the humerus head. You will see a structure which is tightening and relaxing. That is the subscap. Secondly, the subscap is relatively anterior to the MGHL. What you can do, if you're in real doubt, you can try to get anterior to the structure. In MGHL, you will be able to go anterior to the MGHL, whereas you can't go anterior to the subscap. Number one. If still in doubt, you can give a slight cut on the MGHL, and that will actually give you the feel whether it is MGHL or subscap. That is what I actually did in my first case. But this is one thing, you can go anterior to MGHL, and secondly, rotation of the humerus head. These two things actually are the main guides. Now coming after the glenohumeral part and the inferior recess, now coming on to the rotator cuff, we have essentially three tendons that we need to look: supraspinatus, infraspinatus, and the teres minor. Teres minor is not that much looked at, basically supra and the infra. So one thing you have to note is the supraspinatus insertion just begins at the articular margin. If you see any space between the insertion of supraspinatus and the articular margin, any bone, that means it is pathological. There has to be articular cartilage right in continuation with the insertion of the supraspinatus. So it essentially begins just posterior to the biceps. I'll show you in the diagnostic round again. And there should be no bone exposed from the GT. Rotator cable is basically far laterally before the insertion. There's a discrete thickening present in the supraspinatus tendon, which extends from anterior to posterior, which we call a rotator cable. So, and just lateral to it is rotator crescent. Basically, you have to assess for the supraspinatus insertion, and there should be no bone visible between the articular cartilage and the tendon insertion. That is the point. There should be no fraying of the tendon. Then comes the infraspinatus and teres minor. Once you have seen the supraspinatus, you try to withdraw your scope. And while withdrawing your scope, you see the infraspinatus. It's a continuation, so you really cannot differentiate between the two. And while withdrawing further, you will see a bare area. That is the bare area that is between the insertion of teres minor and the articular cartilage. That bare area is an area which is devoid of the cartilage and the tendon insertion. This is the physiological, but this is in the area of teres minor. So it should not be there in infraspinatus or supraspinatus. If it is there, that means there is some tendon which is gone or there is a cartilage lesions. So I'll just basically show the video of this rotator rotator cuff. This is This is supraspinatus. This is supraspinatus, which is inserting here, and there is no space between the supraspinatus and the humerus head cartilage, which is, I would say, any devoid area. Now I'll withdraw my scope a bit, and there is the insertion of infraspinatus in continuation, and further withdrawing here. You can see this is the area which is devoid of cartilage, looks smooth, and actually I could not find my pen drive last night. That area, basically, this is the area what I wanted to point out is the bare spot, which is between the humerus cartilage and the teres minor insertion. So now the only thing left is the posterior structures. Now when we are through with this much of diagnostic round, we switch to the anterior viewing portal and probe in the posterior. We have to look at the posterior labrum, posterior inferior glenohumeral, posterior inferior glenohumeral ligament, and the posterior capsule. First two structures we can still look from the posterior portal, but we get a much better view, especially in pathologies and from the anterior portal. So, and also the subscap recess. As I told you, you have to retract your scope a bit and see the subscap recess from the anterior portal. The summary of the diagnostic round, as I told you, the posterior portal. First of all, we look at the biceps tendon, biceps anchor, then the rotator interval, subscap, SGHL, subscap recess, MGHL, superior labrum. After that, the axillary recess and the pouch. And after you're through with the axillary recess, then you go to supraspinatus, infraspinatus, teres minor, and the bare area, basically the rotator cuff area. In the posterior structures, the labrum, capsule, and the posterior inferior glenohumeral joint, and glenoid, humerus head. I mixed up the sequence somehow. Anyways, glenoid, humerus head, anterior inferior glenohumeral ligament, and anterior inferior labrum. And from the anterior portal, you can look at the posterior glenoid labrum, posterior capsule, posterior capsular recess, and subscap recess. These are the four structures you look best from the anterior portal, and also the MGHL, AIGHL, and anterior inferior labrum. You can have a reasonably good look, especially the anterior inferior labrum in cases of the Bankart lesions. Thank you.
Thank you, Dr. Saurabh. Any questions from any of the panelists or attendees? So I like to invite Dr. Chirag Chudasama for his talk on tips and tricks and how to start doing a Bankart repair surgery. Dr. Chirag, share your screen and can unmute yourself.
So, is it visible, my screen?
Yes, yes.
Yeah. So, good evening, everyone. So, there was a talk by Dr. Siddharth Aggrawal regarding the portals and diagnostic round and position. So, I will not go into detailing about those things. So, I will be discussing mainly regarding tips and tricks of Bankart repair. So, I think the Bankart is the initial thing we should attempt while starting the shoulder arthroscopy, because in initial phases of learning curve, the suture management is little bit difficult while doing cuff, and it is somewhat easier while doing Bankart. So I think most of the people starts with the Bankart. So key steps we will be discussing: position, portals has been already discussed, diagnostic round, then comes the labral mobilization, then the preparation of glenoid, then anchor insertion, and finally repair. So this is the position I use. I do all my shoulder arthroscopy, even cuff and Bankart in lateral position. It depends upon how you are trained, and you can do it in beach chair also. So usually position is about 45-degree abduction, 15-degree forward elevation. These are the principal portals. This is the mid glenoid inferior portal, superior portal, and this is the standard posterior portal, viewing portal, right? You can put a folded towel or roll under the axilla to enhance or to add into your distraction of the joint. So start with the video. So this is the biceps, that is your lighthouse. You just have a quick diagnostic round. This is the rotator cable and intact cuff. You can see a large significant hill sac. This is the inferior axillary pouch, bare spots. This is the MGHL and subscap. You cannot see any labrum anteriorly. So this is the case of antero-inferior instability. So once you have quickly done your diagnostic round and you know what you are dealing with, actually. Then comes the portal placements. So portals are your best friends if you take it properly, but they are worst enemies if you have done error in taking portal. So this is the mid-glenoid inferior portal. You just insert your needle on the leading edge of the subscap and try to approach the lower half of the glenoid and whether see you are able to reach there or not. So that is the trajectory. In initial phase, don't try to penetrate the capsule with the knife, otherwise you will make damage. So it is better to enter the joint with the switching stick and then put the cannula. Usually 8.25 or 8.5 mm cannula is required in this portal for suture management and instrument handling. So this is 8.5 cannula. Always use cannula inserter. There are different kind of inserters. Those are made from different types of cannula. Those which are fitting with the specific mode of cannula. So that is anteroinferior cannula, anteroinferior portal, and this is the anterosuperior portal just in front of the biceps tendon through the rotator interval, and take this portal in such a manner so that you can go forth and back to the biceps tendon. So again, put another cannula or just a switching stick. I don't use cannula because I am going to view the entire procedure through this portal, and it may be overcrowding if you put double cannula over here. So I just put my trocar sheet and insert scope, and I put the 5.5 mm cannula, that is the smaller one, in the posterior portal. So this is the posterior portal and this is the 5.5 mm cannula. So now I am viewing through the anterosuperior portal. So if you are planning remplissage or any procedure in the Hill-Sachs lesion, just prepare your Hill-Sachs area. I put anchor and pass all the threads initially while going ahead preparing the labrum, because if you once you tie the labrum or you repair the anterior capsule, then it is really difficult to visualize this area. So what I do, if I am doing remplissage, I first pass the sutures in for the remplissage to capsule and infraspinatus, and I just park it there and I will tie it later on. So this is the anterior labral tissues and this is the anterior glenoid margin. So if you are lucky, then you are having these typical kind of Bankart lesion. Most of the time, the patients with recurrent instability are having an ALPSA kind of lesions where your labrum is falling far below and it is actually attached to the neck of the glenoid. So you need to mobilize your labrum from the glenoid neck. That is the crucial step, and that this is the only step I think there will be bleeding in the Bankart repair. So go gently, and usually I start at the 3 o'clock position or the proximal most position, I mean cranial most position on the glenoid to start with the liberation of the labrum. So this is the normal, you can see the bleeding once you reach near the subscap, and that is the normal. If it is not possible, then to liberate it with your free hand, you can use a gentle tap of hammer. There are up and down liberators available. So for the 3 o'clock position, you can use the down up 15 degree up, and this is the 15 degree down. So you just go up to the 6 o'clock and liberate or elevate all the labral tissue and tissue attached to the neck. So that will help to pull your capsule up. So this is the bare spot which we were talking about in the previous lecture. So there is practically no glenoid bone loss. So this is the candidate for soft tissue repair rather than any bony procedure. So that should be decided well in advance whether you are planning a soft tissue procedure or a Latarjet kind of thing. So once you elevated your labrum, just make your glenoid neck row, because that will help in healing, and so that you can rasp your glenoid surface and you can prepare the glenoid edge, because in anterior labrum repair you need to put anchor on the face of the glenoid. So just clean the edge of the glenoid with the curette or with the shaver or whatever instrument you like. So once you prepare your this glenoid, you start with the anchor incision. Usually anteroinferior anchor you can put at the 5:30 o'clock position depending upon your side of the shoulder. So I put anchor usually on 1 or 2 mm on the face of the glenoid, but the lowermost anchor, it is slightly more towards the glenoid face, because there are chances if you put it too much on the border, you may penetrate the anteroinferior cortex and your anchor will be out through this anteroinferior cortex. If you are using the flexible anchor, I mean, if you are using the all suture anchor, then you should use the curved drill guide, which is available usually with all the companies. So you don't penetrate the anteroinferior cortex, because this all suture anchors require longer drill holes as compared to other peak anchors or bio anchors. So this is a relatively older video, and there is a purpose showing this video, because there are few tips and tricks which I will show on this video. So this is the video when the all suture anchors were not available, so this is the first anchor at the 5:30 position. Just hold the cannula, hold the sleeve of the drill guide by yourself. Don't ask your assistant to hold this sleeve, because he may lose it, and if you lose the hole, then there will be, sometimes it is difficult to relocate again. So hold this drill sleeve and ask your assistant to put your anchor in. So this is the first anchor going in at the lowermost part, right? So always check for the mark. Usually the marks are available on inside view and even on the external side of the handle. Most of the systems, they are having self-stopping mechanism on the external side of handle. So once you reach the required depth, the handle will stop going further inside the sleeve. If it is not, then you look for the mark inside as well as outside, right? So this is your first anchor which is gone in. So you retrieve one of the threads from the posterior portal. So we are viewing again from the anterosuperior portal, working from the mid glenoid portal. So once you have retrieved your one thread from the posterior portal, then comes your suture passing device. So this is usually 45-degree right or left, whatever side is involved. That is the suture passer. So just go beyond your anchor position. So you want to shift your capsules and labrum tissue up to tighten the inferior space. So just go beyond, just poke your capsule with the suture shuttle device, and this is the step where sometimes it is difficult to negotiate your suture passer. And there is a trick if you are having difficulty in retrieving your suture, or if you are not able to see the tip of the suture passer, then you cannot retrieve your threads or suture shuttle wires. So you can just elevate your tissues with the grabber or suture manipulator, and you can see the tip of the suture passer easily, and just retrieve it from the posterior portal and shuttle your threads. Now this is the step which I was talking about. So this was the knot tying was done by my fellow. So what he did mistake, So if you pass the suture and you make a post which is not through the tissue, your knot will be lying towards the cartilage. So there may be some damage with the threads and knots to the glenoid articular surface as well as to the humeral head. So make a suture post the thread which is passing through the tissue, right? So usually first sliding knot, that can be Duncan loop or SMC knot, whatever you are comfortable with. So I usually take SMC knot for the first sliding knot, and then 3 alternate half hitches, at least 3 alternate half hitches should be placed. So this is the first anchor we tied upon. So now we put the second anchor. Adequate spacing should be there between 2 anchors. If it is too close, then you may enter the previous anchor's tunnel and there will be a coalescence and loosening of the anchors. And if you are too away from the first anchor, then your anchor position will be not proper and you will be having not proper space for the third anchor. So at least 3 anchors are recommended for the Bankart repair, 3 or 4, but optimum is 3. So 3 anterior anchors are the must numbers at least. So this is the second anchor going in, and if you are having, so sometimes some surgeons prefer viewing from the posterior portal and putting anchors and all these suture shuttle managements and this from the while viewing from the post. So I do all the procedures for Bankart repair while viewing from the anterosuperior portal. So it makes your vision somewhat more easier while looking from the front. So this is the second suture shuttle device. So now if you have passed the first suture, then it will be easier. Again, poke with your suture shuttle device and then ride on the glenoid neck and then you rotate your suture shuttle. Otherwise, you will be having always problem while passing these suture shuttle wires. So again, the same step, retrieve it through the posterior portal and just shuttle your anchor thread through these wires or nitinol loops and then tie the knot, and it will create a nice capsular shift and a bump. So you can see a nice bump is created anteriorly. So that should be there in your Bankart repair. So you are not only repairing the labrum, you are plicating the capsules as well. So you need to shift your capsule upwards and you must have a significant amount in your of capsule in your repair. So this is the second anchor which is being inserted. So first sliding knot, that is sliding locking knot, and then alternate half hitches, 3 alternate half hitches should be there and cut it. Right, so that was the second anchor, and now the third anchor. So usually this is, the third anchor is around at 330 position, and there is a controversy in this anchor regarding whether you should take the MGHL in your bite or you should not. So usually in hyperlax patient who are having somewhat laxity, I take my MGHL in my bite if it is required. Otherwise, I don't take MGHL in my bite in this 330 position anchor. So this is the third and last anchor for the antero-inferior labrum repair. So as I said, at least 3 anchors are optimal and you should place at least 3 anchors. If you place your first 2 anchors at a far distance, then you may be having problem putting the third anchor, that is the 330 or 3 o'clock position anchor, and you may end up with only putting 2 anchors. So adequate spacing is very important. So again, take care, you are not biting your subscap, you are not taking your subscap in this bite. So this is, here there will be subscap, right? So this is the subscap, and you are biting your soft tissues along with the MGHL. So it is difficult to visualize MGHL from sometimes from the anterosuperior viewing portal. So this is the suture for the, so again the same sequence, you pass the suture, you retrieve it, you insert the anchor, you retrieve one of the limb from the posterior portal, pass the suture shuttle, and then you shuttle the sutures and tie it, right? So once you have finished your labral repair, so you can see a nice bumper effect on the anterior aspect of labrum. So you are not even now easily able to lift the glenoid head as it was able to do so previously. So once you have done the anterior inferior repair, now I will tie the remplissage sutures. So this is how I have not shown tying because it is the extra capsular. So you are not able to visualize through inside view of the scope. So this is how you can see the centralized humeral head over the glenoid, and this is the end of the procedure. Thank you. So we can take any questions if you are having any question.
Dr. Chirag, there is a question from Dr. Devan Dave,
Yeah.
and it is regarding the preference of suture anchors in your Bankart repair. All suture versus the others. What is your preferred suture anchor?
I usually use the lowermost anchor. I usually use the peak kind of anchors. I never use metal anchors in the Bankart repair because if by chance your metal anchor is exposed, then it may just damage your humeral head and that can lead to a catastrophe. So I have never used the metal anchors in Bankart repair. I use lowermost anchor, usually peak, and the rest all suture anchors. Because the reason what I told, the lowermost anchors, the all suture anchors require deeper penetration, and you may have the anterior cortex blowout, or you may penetrate the anterior cortex in the lower part of glenoid. So with the help of curved drill guide, you can use the lowermost anchor all suture anchors. So preferably all suture anchors for the Bankart repairs. Yeah.
Dr. Chirag?
Yeah.
What is your opinion about temporary outside traction stitch? What about putting a like suture in the labrum and pulling it?
Yeah.
While you do
So it definitely helps. So in some cases, like I said, in ALPSA lesion, where your glenoid labrum and capsule are falling far medially, and if once you have adequately liberated your tissues, it will come forward. But while you are planning a shifting and you are not able to bite adequately inferiorly, then distraction stitch on the anticapsule and labrum definitely helps. Yeah. So sometimes I do it.
So my concern was while you're viewing from the anterior superior portal. So where do you pass your stitch from?
Viewing from the anterosuperior portal, and I
the superior portal. That is the portal. If otherwise, you will have put the stitch. So where?
No, I'm putting stitch from the mid-glanal portal. So traction stitch from the mid-glanal portal. So again, pass the anchor and then keep the traction stitch on the mid-glanal portal only, and introduce your suture passer from the mid-glanal portal and penetrate the capsule and labrum. So the traction stitch is in the anteroinferior portal, and passing of the suture shuttle device is from the same portal.
Okay, you do both from the same portal.
Yeah.
Okay. And how far do you release the labrum, you said, up till 6 o'clock?
O'clock, yeah, up till 6 o'clock.
Okay, what most of the times now it's coming up, the most of people prefer to release if possible up till 7 also.
Yeah. So what happens? I have seen some surgeons like Dr. Sugaya who is releasing always up to the 7 o'clock position.
In one of the
But you need to cut the normal labrum if you want to liberate. So I don't like to cut the normal labral tissue which is well attached to the glands. So I'm going down beyond the 6 o'clock position below the labral tissue, but I don't like to cut the labral tissue which is normally attached to the bladder.
for the youngsters. Anything else? I would suggest one more thing, that if you are facing difficulty in passing the stitch through the suture lasso, you can use anti-grade suture passer.
Yeah, that is the trick you can use. So like express shoe or scorpion, you can use for the inferior-most suture passage. That is correct.
That is a trick, especially in the initial part, because sometimes you find it difficult to, manipulate your first stitch. That is the most important one, the difficult one. So initially you can use it from the opposite side. Is posterior portal, you can use anti-grade suture passer.
True.
Now I'd like to invite Dr. Saurabh Mathur for his talk on basics of rotator cuff repair and tips and tricks in rotator cuff repair surgery. Dr. Saurabh, sir, please.
Okay. Okay, so can you see?
Yes, sir.
Okay, so hi Siddharth, good talk on the basics, and rest has been covered by Chirag, all good friends. So I'll be talking on cuff repairs. So definitely cuff is not the first thing to start in shoulder arthroscopy, but yes, it is one of the most important shoulder surgery, and we all should know. And if we know the basics of positioning, basics of portals, and basics of diagnostic, we can easily do a cuff. There might be a few things which we need extra for the cuff, and which I always advise the beginners to start with is a pump. Other from all other things, we should have a pump. Definitely, shoulder pump gives us a better view and better visualization. Second thing is a good anesthetist who can keep your pressure low, because when doing a cuff repair, we are practically outside the joint. So we are doing it extra-articularly. So we need to have a good anesthetist who can keep our mean less than 80. And third most important thing is RF. So these are three things without which we can easily do a Bankart repair or intra-articular surgery. But for rotator cuff repair, we definitely need all these three things. Otherwise, we should not give it a try. Am I right, Prathmesh?
Yes, sir.
So we'll be dealing with a simple case of a rotator cuff. As you asked me, that it should be it should be for basics. So it's a fresh tear, relatively fresh tear, 2 months old, 65 years old female. She had a complaint of pain, loss of sleep, more pain at night, injury right shoulder, passive range is full, which we see clinically, but drop arm positive. So drop arm positive indicates that she has a full thickness supraspinatus tear. Along with that, other external rotation was also reduced, not reduced, but strength was less, but subscap was normal. So first investigations, what we go for is X-rays. X-rays is first thing to rule out X-ray fractures, whether there is a tuberosity fracture or any other impaction. Second thing, to see the alignment of the glenohumeral joint. Right? Most important investigations for rotator cuff injuries are MRI, and in our case it shows a full thickness tear which was slightly retracted, not much retracted. But most important thing, what we should see is the bulk, muscle bulk, whether there is atrophy of supraspinatus or not, because that will give you the duration of rehabilitation, maybe the amount of effort you need after surgery, or maybe it will give you idea whether you should touch it or not touch it. So this is a lateral position, like Siddharth has already told us. So we'll be doing, video is not running, I suppose. Is video running?
No, video is not running, sir.
It was running. We just tested it before.
Just
Anyways, it was
stop
just,
and start, sir.
yeah.
Now start, sir. Now it's running.
Yeah, it's okay. So that, anyways, that film was of a position and portal placement, which has already been covered by Siddharth. So nothing much doing. But one thing regarding position, which I want to mention, is that when 10 years back, when we were used to train in outside India, now we have a lot of centers in India for the shoulder training. We were trained mostly in beach chair position. Because they have good equipments and all the things. But once coming back to India, it was very difficult for us to do a beach chair thing because it is not available everywhere. And like all other arthroscopic surgeons, I started my career as a freelancer. Getting a beach chair in every setup is not easy. Second thing, your anesthetists, maybe in periphery or most of the anesthetists are not very comfortable with the beach chair position. So gradually, even after getting my training in a beach chair, I gradually turned to lateral position. So now I've started doing all my cuffs and Bankart, everything into the lateral positions. So it all depends how you are trained, but definitely looking at the logistic part, beach chair position is easy position as far as our country is concerned. So we'll just go for an intra-articular scope and we'll just try to see the this slide is particular what Siddharth has mentioned already, that you should not see bone after the articular cartilage. If you see bone after articular cartilage, this means your cuff is gone, your supraspinatus is gone. So this video represents that. So first you do an intra-articular scope, you confirm your diagnosis, but then you have to go to the subacromial space. So once your diagnosis is confirmed and you have done an intra-articular scope, you go to the subacromial space. Subacromial space is basically extra-articular space. So here, usually you will find lot of adhesions, bursa thickened. So it is rotator cuff surgery is basically you need lot of patience. It cannot be done in a haste. So first you take a needle, you make a lateral portal, and because it is usually thickened with a Wissenger rod, just open it up and then do a bursectomy. So just take some time, there will be some bleeding, but you take a RF and gradually, slowly remove all the bursa. So more you clean, more clear vision you will get. And finally, what you will be able to see will be a torn cuff tissue. But it takes time and you need to clear all the bursa slowly without damaging the cuff. So this is what you see post debridement. This is what you see post debridement. So this is this supraspinatus cuff, you can see. And see, once all the bursa is gone, all the adhesions we have cleared, we can clearly see this articular cartilage here. This is the footprint. This is supraspinatus tendon here, biceps here, subscap coming there, and a part of infra here. So this is the final picture what we see after post debridement. So debridement part is very important. Remove all the bursa. It will help you later on taking the bites. It will, and if you clear it properly, your surgery will be smooth. After that, we'll switch our portal towards the lateral side and see the bullseye view of the tear. So what are the advantages of bullseye view? First of all, you will be able to see that your cuff is not laminated, because it is very frequent to see a laminated cuff. And if it is a laminated cuff, you need to take the bite of both the laminations, and mostly the degenerative cuffs are laminated cuff. Second important thing, what you will be able to see will be the adhesions. So if there are any adhesions between the acromion and the supraspinatus tendon, you'll be able to see that, and we can release all those adhesions. After that, next step is, once you remove all the adhesions, all the bursa is gone, you prepare the footprint and mobilize the cuff. So mobilization of cuff will give us the fair idea of the pattern of the tear, whether it is a L-shaped tear, whether it is a simple tear, whether it is a reverse L-shaped tear. Because once you take the complete cuff to the footprint, you'll be able to know what exactly is the pattern of the tear. That is why I always say that doing a arthroscopic surgery gives you a better visualization of the cuff and a pattern than a open or a mini open, which initially people used to see. After that, next is anchor marking. So we need to see how many anchors we can place. So just use a needle, just go lateral to the margin of the acromion, and we can see at the dead man's angle. So dead man angles is basically 45 degrees from this place. So this dead man angles, we go for our anchor. So before I tell you details of the anchor, just want to tell you a basic thing. What I usually do and what is like a basic arthroscopic surgeons should do is a single row repair. Though there are many discussions, and everyone will have their own opinion of a single row, double row, and so many things. But how to do a basic single row repair with a peace of mind is just take a double loaded anchor. Here you can see it's my cuff tissue. This is my anchor. It is a double loaded anchor. We take one mattress. Say this is anterior wing, posterior wing, one mattress suture, and one single loop. Okay. So first we take this mattress suture. This mattress suture, what it will cause, it will create, it will bring the cuff tissue over the footprint. Then with a single suture, with this single suture, we'll just take a simple knot. So what are the advantages of this? There will be three advantages. First, your suture will come up to the footprint. Second, there will be a mattress suture. So this mattress suture might create a dog ear. So this transfer suture will reduce that dog ear. It will reduce the cuff to the bone. And third, this transverse suture will prevent the cut through of this suture. So it gives three advantages. This is known as a modified Mazzanelli technique, and it is a perfect way to do a single row technique without failure. So here we can see when we take the bites. This was my first bite of the first thread of supraspinatus bite, which was a transverse, which was a mattress suture. This was the single suture, which was of different color. And now I'll take a bite of a second limb of my mattress suture. So this is my second limb of mattress suture coming. See, you can see my second limb of mattress suture coming. And I'll take this mattress suture. Now, there are many ways of taking the bite. Some uses suture passers. You can use a self-trap devices. You can use many different devices. I'm still using Expressive 3. Now I've recently started using with the self-trap devices. Otherwise, for last many years, I'm using these simple devices because I need to take suture limb to the other side. Once your one anchor is placed and all the sutures taken, we need to see the location of the second anchor. And this is very important because how far you should go from your previous anchor. So usually it should be 6 to 10 mm from the previous anchor so that you give sufficient strength to the cuff and not coalescing the two anchors with itself. So second important thing which I will advise you as a beginner, if you are having a female of 65 years old age, your awl should not be, it should be a simple awl, not a threaded one or something, because usually these are osteoporotic bones and there are chances that your anchor may get loose. So always get ready for something like a 8 mm anchor standby. But to reduce the chances of loose anchor, always try to use a awl which is a size smaller than a usual one without tap. So this is how my second anchor goes in. And now the important thing is taking the posterior cuff bites. So from my anterior lateral portal only, I'm easily able to take the posterior cuff bites also, visualizing it from the posterior lateral portal. So now comes the suture knots. So what we usually do, we start taking bites from anterior to posterior and we start tying them from posterior to anterior. So we tie posterior part first, and then it is the same way. It's a modified Masonelli. You can see this is my transverse mattress sutures which has been tied earlier. Now this is the simple transverse suture which will now bring the edge of the cuff to the footprint. And this mattress suture will prevent the cut down or cut through of this simple suture. This is a final picture. We can see footprint has been covered completely and cuff reduced and repaired. Again, second important thing is subacromial decompression, which is again a point of discussion, which we'll just discuss with Chirag and Prathmesh, whether they are doing it or not. But if I find any subacromial spur, if these are degenerative non-traumatic cuff tears, I always do subacromial decompression, remove all the spurs and everything and come out. There are many papers coming nowadays that no need of doing subacromial decompression, but I still feel that subacromial decompression, if there is a spur, should be done and it should be cleaned properly. Thanks. So any questions?
How frequently are you doing subacromial decompression, Dr. Saurabh? Like in all the cuff tears you do as a protocol, or in whenever you feel there is a spur, or just as a routine?
I tell you. In non-traumatic cuff tears, 100%. 100%. In traumatic cuff tears, if there is a spur, then only. In young patients, traumatic, I don't think it is required, and usually we don't find subacromial spurs also. Prathmesh, you are doing subacromial decompressions?
Yes, sir. Approximately 50 to 60% of cases.
50 to 60%.
Total overall.
So, so do you also differentiate like
Yes.
what I am doing in
Yes,
degenerative?
yes,
I do traumatic.
yes,
I don't.
Yes, yes.
Like
More in degenerative, less in traumatic.
One more burning question, and controversy: whether you are doing subacromial decompression in routine without cuff tears also or not? If there is a bony impingement or not?
Not exactly.
Prathmesh?
Yes, in very selected cases.
Yeah. See, because I tell you, there are so many papers and theories are coming nowadays, but we have been doing subacromial decompression from last 10 years with a very good results. So I don't know whether I don't have any study or to prove that, but we are doing subacromial decompression from last 10 years with the symptomatic patients who have a grade 3 spur, and they have given us really good results. So I don't know why it is like not used nowadays. Chirag, what is your view on this?
Yeah, I do in selected patients who are having definitely spur on the X-ray and MR, and patient is properly
Symptomatic.
activated. So I do sometimes.
Basically, in case we have a spur and the patient is symptomatic, then we can go ahead. But like you need to have a proper type 2 or type 3 acromion.
Okay.
Should be
Now,
sure.
one more controversial thing: double row or single row. So I think most of the participants who are young, who are doing or just want to start, company guys come and say, "Sir, you should do a double row." What is your take on it?
Single row is good. And once you're through with a single row, when you have those sutures in hand, hammering one double row, second anchor on the lateral row doesn't really harm much. When I started with initial part, I was sometimes not very sure about the medial row hold or something. So hammering a lateral row, one anchor doesn't, cause any disadvantage, I feel.
See, there are many studies which says in a double row, there is very high failure rate of medial row because of stress on medial row. There are many studies now. Plus, second thing is, again, if you go through the literature, it says there is clinically, on functional outcome, there is no significant difference between single row and double row.
That is well taken.
In my case, I only go for double row when I feel that after doing a good single row, there is a dog bone or some cuff is still coming up or lateral margins are rolling out. Then I go for a double row, but otherwise, it's not like a routine case.
Short 65-year female. She must be having a relatively osteoporotic bone.
Right.
So don't you feel it more secure when you put a double row or the second anchor in the lateral row, so that
it depends when you put your how you feel when you put your first anchor, medial row anchors. And I tell you, the the hardest bone in the head of humerus is subcortical bone. It's not even the lateral bone. It's the subcortical bone which is the hardest bone. So when we put the anchor at 45 degrees and it fails a lot of time. It fails. Using a same hole, just try to put it in a subcortical area. It will give you a hold.
You are saying?
Sorry?
Subchondral.
Subchondral, sorry, not subcortical. Subchondral area. In the subchondral area, and you will feel a good hold in that bone. So that is again a trick which time has taught us. So
okay, that's nice. So
Dr. Saurabh, there are some questions from the audience.
Yeah.
One is, how do you handle old massive cuff tears and irreducible cuff tears? And do you use a single loaded, double loaded, or a triple loaded anchor?
Okay, so I usually use a double loaded anchor. I never use a single loaded anchor for cuffs. Triple loaded anchor I have rarely used for a massive cuff, but mostly double loaded anchor. First of all. Second thing is, if it is an irreducible cuff, then it all depends on the age of the patient. If it is an irreducible, irreparable cuff, then and patient is 60, 65 plus, then preoperatively only my choice will be to go for reverse arthroplasty, because 65 and irreducible cuff. Second thing is, if it is younger patient, the option what we can give is a superior capsular repair or a tendon transfer. Then it all depends how many cuff tissues has gone, whether subscap is also gone, infra is also gone. Isolated supra, you can do a tendon transfer, though results are variable, you cannot guarantee the results. And superior capsular reconstruction, which I have not done till now, but yes, as per literature, it is one of the options to the irreducible cuff young patients. Yes, Prathmesh, what do you say?
What are the options in massive cuff tear? How do you do a release?
Massive cuff tears, yes. So for irreducible, one is interval release is also one of the option. And though I have never done, but I have seen few videos of yours. You're doing the interval closure, interval release and all. So for massive release, you need to go as posterior medial as possible till you see the fat pad. And but it has to be very slow, and it has to be with radio frequency. You need to release or the adhesions, and usually it comes after that in the massive also.
So correct. So Prathmesh, what are the reasons for posterior interval slide you are doing frequently? As in my practice, I am not doing the posterior interval slides. So can you elaborate why and when you do posterior interval slide?
So posterior superior tears, irreducible or reducible under high tension. These are the three indications that I take. If the cuff tissue is not coming up to the footprint, you can do a medialization of up to a centimeter or so. And if it is still tight, then I would like to do a release. First, I'll do an anterior release. And then if it is not coming up, then we'll do a posterior kind of a posterior interval release.
Posterior interval release. So, and how are your results with the posterior interval release? Because I'm not doing it.
The results are good, sir. Most of the patients are happy.
Okay. They are painless.
They are painless and they are happy.
So I have done few tendon transfers. They are painless, but their strength is not very much, but they are happy. I don't know why. But
which tendon transfer do you do, sir?
See, earlier I used to do leg dorsi only. Posterior superior, for posterior superior, leg dorsi transfers.
I think we have covered everything about the cuff. Any other questions from the audience regarding all the three talks? You can just write on the comment box on the question and answer. We'll be happy to take all the questions. Okay then. Okay, then I'll just take a small talk of mine about the stiff shoulder. And can you see that? Is it seen, sir?
Visible.
Yes. Okay. So adhesive capsulitis is one of the most common shoulder ailment, and it will be the most common diagnosis when a person starts to do a shoulder arthroscopic surgeries. And it is most common in females about 40 to 60 years of age. And it can be a primary frozen shoulder, or it can be a secondary frozen shoulder. A primary frozen shoulder or adhesive capsulitis is usually idiopathic, and a secondary adhesive capsulitis can be either a post-traumatic or can be a secondary to a surgery. Now the treatment of both of these is little different, and I'll be coming on to that. So now, if it is a primary or a idiopathic kind of a adhesive capsulitis, you can straight away go and do a intra-articular arthrolysis. Whereas if it is a secondary kind of a adhesive capsulitis, which is probably secondary due to any trauma or any previous surgeries, you need to do both intra-articular as well as a subacromial work. And if there are some implants associated, like any screws or plates inside, then probably you have to address those implants as well. Now, as I told you, secondary adhesive capsulitis will be a common thing in your practice if you see, because most of the post-traumatic scenarios like plating or something like that cannot get full motion sometimes, and it can be without a fracture fixation or a fracture fixation. And in these cases, there will be intra-articular adhesions as well as a sub-acromial adhesions present. Now, the natural history of adhesive capsulitis is in 3 stages. Stage 1 is freezing, stage 2 is frozen, and stage 3 is thawing. But this is a more of a theoretical staging pattern, and not all of our clinical patients will follow these stages. But definitely, initially it will start with pain, and then it will be stiffness, and slowly they will resolve over time. There is a good association of a diabetic, uncontrolled diabetic and uncontrolled hypothyroidism with the incidence of adhesive capsulitis. And X-ray is always mandatory, because many a times the patient has been diagnosed as a frozen shoulder and adhesive capsulitis and is being continued treatment for that, but actually it is not a adhesive capsulitis, but actually a osteoarthritis or a locked posterior dislocation, which can be easily picked up in a X-ray. So always do an X-ray for a patient coming to you with a stiff shoulder adhesive capsulitis. And MRI is desirable, but it is not mandatory to treat. USG has not got important role in this particular indication. Now, as far as the MRI is concerned, there is a very good indications. The MRI features are edema in the IGHL, anterior and posterior pericapsular edema, fluid around the biceps tendon, obliteration of the fat in the subcoracoid triangle, thickness of the humeral and the glenoid portion of the anterior band of the IGHL, thickness in the axillary capsule at the axillary pouch, thickness in the coracohumeral ligament, and decreased height and width of the axillary pouch. So this is a feature. This is a MRI which shows increase in the rotator interval. You can see hyperintense tissue in the rotator interval tissue, which is suggestive of a tight rotator interval, and finding suggestive of adhesive capsulitis. And if you see downwards, you will see that the inferior axillary pouch is obliterated and it is tight. And if you see here in the second image, you will see a slit-like axillary pouch, which is very characteristic of a stiff or shoulder or adhesive capsulitis. And if you see up, as we were discussing earlier, you may see impingement phenomenon in many cases. So impingement can be a associate factor for a secondary kind of a adhesive capsulitis. Now there is a staging system based on the MRI. The stage 1 is basically the IGHL thickness, only thickness with edema. The stage 2, the thickness of the IGHL band will increase. The stage 3, the IGHL thickness will be there, but it will be decreased with the decreasing edema. And in the stage 4, the thickness will decrease still further, and there will be no edema. So it will be a sort of a resolving kind of a stage. Now, intra-articular steroids has been advocated since long for use in adhesive capsulitis. They works on the principle of the chemical ablation of synovitis, but nowadays it has to be used with a little caution. Similar with the manipulation under anesthesia using a short lever arm technique. This was a popular technique few years back, and you do it in the order of a fear, that is flexion, extension, abduction, and external rotation. It is not in my personal preference because it can cause some kind of complications like dislocations, fractures, cuff injuries, and typically the labral kind of injury with the anterior sort of a chip fractures of the glenoid. Now, this is one of the procedure or one of the surgery in which I seriously admit that I have done a lot of complications myself in my starting days. So initially, if you choose a case of a stiff shoulder or adhesive capsulitis, it will be a difficult case because entry into the shoulder will be little difficult. And occasionally, if you force your scope or force your trocar, you might go into the humeral head itself, or you can do scuffing of the articular cartilage. So it has to be done with extreme caution, because here the chances of iatrogenic injury are high. So my personal algorithm is, if an atraumatic portal, if you can make easily, then you can go ahead and do a intra-articular work, intra-articular adhesive lysis. If you cannot make a atraumatic portal easily and you feel there is a very tight kind of a capsule, you do a gentle kind of a manipulation. This manipulation should not be forceful, as I told you earlier. So we don't recommend manipulation as a therapy for a stiff shoulder. But if it is, you can just do a very little gentle manipulation so that you just make the space so that your scope can enter, and then you can do a retry. If you can go into the shoulder, it is fine, well and good, and you can go ahead with your intra-articular arthroscopic arthrolysis. And if still you are not able to enter into the joint, then it is better not to use that approach. Just abandon the use of this particular technique and shift to a procedure which is called as an extra-articular arthrolysis. So I'll just be coming to what is the extra-articular arthrolysis. Now, as I told you, there are two arthroscopic approaches. One is a conventional arthroscopic arthrolysis, which I told you that occasionally it may be a difficult portal access and chance of doing an articular cartilage damage. And second is an extra-articular arthroscopic arthrolysis. It is a newer technique. It needs a little bit of more skill, but it is safer and it is easier, and it gives you peace in the mind. So it prevents complications in your hand. So this is a small video showing a intra-articular arthrolysis. It is pretty a straightforward thing, and you should do it in a 360-degree angle, starting from the top to the bottom, and then you can go around 360 degrees using all the portals that Chirag has wonderfully described in his talk on Bankart repair. You usually go from the MGHL, then IGHL, anterior band, posterior band, and you may release the adhesions anterior and posterior to the subscapularis as well. So this is if you can enter the joint easily without a problem. Now, the tips and tricks of doing an intra-articular arthrolysis. Very important, avoid any forceful manipulation. We don't recommend and don't encourage any forceful manipulation because that can cause complications. Avoid iatrogenic injury. Avoid forcing your trocar and cannula forcefully into the joint. If you are doing a release, go from superior to inferior in your release. Whenever you are doing an inferior release, be very careful of the axillary nerve. And the trick to prevent injury to the axillary nerve is you keep your wand closer to the glenoid and keep your wand at a low temperature. Now, this is a small video. This is basically an extra-articular arthrolysis. So as I told you, I use this technique specifically if I'm not able to make a safe and secure portal with a posterior portal. And if I am struggling to make my posterior portal because of a tight capsule. And in that case, I'll go on the subacromial space, just like you do any other rotator cuff surgery, and you do a subacromial debridement. It will not be a difficult thing because most of these patients will not have a significant subacromial bursitis or adhesions. If it is a primary kind of a adhesive capsulitis. And then we will go into the rotator interval tissue and we will identify the biceps tendon. And this is the biceps tendon which we have identified in the rotator interval tissue. And after that, what we can do is we can just release the biceps tendon on. And in most of these patients whom I am operating for a stiff shoulder adhesive capsulitis for a frozen shoulder, I will be tending to do more of a biceps tenotomy in these cases, because biceps in these patients, many of these patients will be pathologic and will be also a cause of pain. So most of these cases, I would like to do a release of the biceps, and usually I do it from the attachment. So from the superior labrum kind of a thing, you will just do a biceps tenotomy. So once you do a biceps tenotomy, then you need to release a little bit more of the tissue from the rotator interval thing. This will be a tedious procedure because some of the times you will see a lot of bleeding here and it will be difficult to triangulate. But as I told you, it will take more time, but it will be a more safer approach than causing a iatrogenic harm to the cartilage and to the bone as such. And here we are doing a tenotomy of the biceps. And once we do a tenotomy nicely, and you release some tissue in the rotator interval area, then you will be able to enter into the joint nicely through this window, which is called as a rotator interval window. And this is now the humeral head you can see, and then you can go in nicely with this superolateral portal. And from here, you can just do your releases from the top. And these are a little bit of releases that we want to do. And be very careful. We don't want to injure a rotator cuff. The supraspinatus will be back there. So we don't want to injure the supraspinatus tendon there. Now we will like to identify the subscapularis tendon. The structure you see on the back is the subscapularis tendon. And we want to release the adhesions anterior and posterior to the subscapularis tendon. So we release the tendons, the adhesions anterior and posterior to the subscapularis tissue. Again, we will be using a lot of shaver and RF in that particular area because it will be a tight kind of a space and mobility will be difficult. And once you do that, then your mobility will be increased. And at this point, you can even make your posterior portal. And this is the anterior portal. This is a standard portal that we make. The structure that you see here is the subscapularis tendon. And now we can do a release of the subscapularis tendon anterior and posterior. And as Siddharth was mentioning, the structure which is anterior to the subscapularis tendon here in this area is the MGHL. And here we would like to release the MGHL. So with our arthroscopic scissor punch, we release the MGHL here very nicely. And then you can use your RF to release more of the capsule. And once your MGHL is released and you have released the rotator interval, then you will be able to make all your portals, including the posterior portal and the anterior superior portal, everything. And then you can do your standard, if you are able to make your posterior portal with a Wissinger rod, then you can do your standard releases like any other procedure. And the structure that you see here down is the anterior band of the IGHL now, because we have released the MGHL. The subscap is seen right here. And this band is the anterior band of the IGHL. And then you can use either your RF and your cautery to release this anterior band of the IGHL. And once you release this, your shoulder will be supple enough to be to get any of the portals you want to use for doing your. So this is the final step. We are releasing the anterior band of the IGHL. So once we do this, the shoulder will become very supple, and then you can use any of your portals to make your releases. So you can insert your Wissinger portal from the posterior portal, and you continue your standard intra-articular arthrolysis kind of a picture. Now, this was actually an approach which was described by Laurent Lafosse in Arthroscopy Journal in 2012, and these are the beautiful pictures he has published in that article. And these are the videos, and this is, you can see that there is a 360-degree release nicely done with the glenoid very nicely exposed. Now the sequence in this particular technique is sub-acromial bursectomy, release of the rotator interval tissue, addressing of the biceps tissue. I usually recommend a tenotomy in almost all of my patients. And then you do an anterior and posterior release, and in the end you do an inferior release, taking care of the axillary nerve. Don't be very aggressive in the inferior portion. So the tips and pearls of this particular approach is you need to do it in lateral position. You do it in an abduction neutral position. Start with the subacromial decompression. You enter into the joint through the rotator interval tissue. Do an extensive subscapularis release, both anterior and posterior. And you view the joint superiorly through the rotator interval tissue. And then you release the anterior capsule through the anterior portals and the posterior capsule by the posterior or the anterior portals. And you must remember the axillary nerve anatomy. The axillary nerve starts from the anterior and it goes to the posterior part of the shoulder, just inferior to the shoulder and through the quadrilateral space. So you should always be careful about axillary nerve when you are doing this particular surgery. Be always close to your glenoid. So for this, the tricks to prevent injury to the axillary nerve, you remain closer to the glenoid than to humerus. It is closest at 5:30 to 6 o'clock position. So you be very careful at that particular position. The safest position is abduction neutral. Don't do it in a lot of abduction, and release it closer to the glenoid and keep your vent temperature low. Post-operative, you can start immediately, mobilize the patient while he is in the block, give a good pain management, and start early active physiotherapy. So these are the basic things that you want to do while doing a arthroscopic release of a stiff shoulder. Thank you.
There are a few questions from the audience. The first question, I don't know the name, but the Redmi. But do you do biceps stenosis also?
No, in case of stiff shoulder, I don't do biceps stenosis because I don't want to do any surgery which can cause more stiffness, and I don't want to immobilize this patient also. We want to immobilize them fast, so I never do a tenodesis in a stiff shoulder.
Correct. So I think the biceps in the stiff shoulder, there is a capsulitis already there in the groove of the biceps. So biceps, I don't think there will be Popeye deformity.
Usually the Popeye deformity will not be there.
Yeah. The other questions from the Suryakant Purohit. So what is the right term for stiff shoulder? Is it frozen shoulder, adhesive capsulitis, or periarthritis?
So all are right, but personally we should use adhesive capsulitis in our medical records.
Dr. Prathmesh, I want to differ in this. Recently, there was a meeting organized by SESI, and they had a long discussion on the nomenclature. So, what the ISACOS committee suggests is the frozen shoulder being the right term.
Okay.
Adhesive capsulitis is a misnomer, and the consensus and worldwide thing that is coming up is frozen shoulder is the right term. It looks like more like a layman term, but it is the right term to be used, and I think that is the context of this question, basically what he wants.
Siddharth, actually all these things are so dynamic that the same meeting which was organized maybe 5 or 6 years back with the same persons.
I think last month it was organized on that. SESI organized this series of webinars.
Yeah, I know. And there was one earlier. There was a group of our shoulder arthroscopic surgeons, and we used to have a meeting on every Indian Arthroscopy Society meeting, where only it was by invite, where only shoulder surgeons used to meet. And it was, I think 4 or 5 years back, it was decided that we will call it adhesive capsulitis. Okay. And what you were saying that frozen shoulder is, I think 3 years back, we have decided to call it a frozen shoulder. So it's a dynamic thing, and it's, I don't think it
matters actually.
Matters
actually. No difference actually.
One more important thing, Prathmesh, what I want to mention is that we all know that because of adhesive capsulitis or maybe frozen shoulder, the capsule, inferior capsule is so tight that it usually pulls axillary nerve up. So it makes it more dangerous to operate in that area. Because my teachers used to tell me that you release not 360, you release it 350 only, and 10% you leave inferior one and do it by manipulation. It won't do a dislocation kind of thing, because the rest you have done it cleanly. Because axillary nerve usually it is pulled up with the capsule and it is in the adhesions. So there are very high chances that by releasing it with the RF, we can damage it. There are many people who are doing it with the scissor punches and all. Second thing, Prathmesh, I want to ask, when you're doing this biceps stenotomy extra-articularly, your scope is in the posterior portal only, or you are taking
this
it to the...
This is actually a lateral or a posterolateral portal, sir.
Posterolateral
to the posterolateral. Just because the same portal that you are using for the bird's eye view.
Okay, right. Because it is very difficult from the posterior portal to visualize the subscap.
Yes, this is more of a lateral portal, sir.
More of a lateral portal. And any other specific technique how to find out biceps extra-articularly?
So what you can do is you can follow the coracoacromial ligament, and then you can reach up to coracoid anteriorly.
Right.
And through the coracoid, there will be some, sometimes you can identify the coracohumeral ligaments. So you can identify and release that area. So there will be a little bleeding, but you can do a gentle debridement in that area. And with some little bit of effort, you can usually be able to find the biceps in that particular area.
And how frequently, while doing an intra-articular capsular release, you are releasing the CA ligament from the coracoid?
The coracohumeral ligament, sir?
Coracoacromial ligament.
I don't do a coracoacromial ligament.
You don't do it because there are few books that mention that you have to release the part, because it is also when you release a rotator interval just anterior to that on the coracoid, you find that thing. Okay.
I don't release the coracoacromial ligament. I release the CHL if it is there. Coracohumeral ligament, if it is there, a part of it can be released.
Right. Because there are few people who release coracoid completely, so they say that it causes it is also a cause of a adhesive capsulitis.
So to all the panelists, what is what are your take on stiff shoulder with cuff tear, that is traumatic cuff tear, medium size? Usually small tears are more stiff, but if there is a stiff shoulder with large cuff tear, what will you do? Prathmesh?
Prathmesh, yeah.
I like to wait and mobilize them and do when the range is good.
Okay.
Usually, I'll not be very aggressive in these patients.
How much will you wait?
Maybe about up to 2 months, up to 2 to 3 months.
So, see if it is a large tear with elderly population, see 50 plus, and are you worried about the repairability and cuff atrophy by waiting for 2 months?
Usually not. Usually not. If it is a stiff shoulder with a cuff tear, the cuff tear followed by stiffness or vice versa, I would like to wait before doing a surgery, because I have burned my hands in couple of cases in which I have done cuff repairs in a stiff shoulder, and then the patient have not done so well.
Not happy. Do you think giving an intra-articular steroid or is an option in a cuff tear with a stiff shoulder?
I don't recommend steroids much in the shoulder, sir, as a routine.
Okay, so can we do a test? Just for the beginners, can we do a test? We just put
Steroid, yes.
No, not
Theoretically,
steroids.
yes.
Okay.
If a patient with a cuff tear with a stiff shoulder comes to us, we just put local anesthetic and check the mobility, whether it is actually stiff or it is stiff because of pain. And if there is a range, can we operate it, Prathmesh?
Maybe, but I'll be very skeptical.
Skeptical.
I'll
Yeah.
be skeptical.
We all are very much afraid of doing a stiff shoulder for the repairs.
Either way you operate it, you wait and then you do again the repairability. I burnt my fingers the other way around also. So it is a double-edged sword. Either way you do it, you are in for a trouble. I feel a stiff shoulder with a massive cuff in a elderly 60-ish population, that is something you are in for a trouble. That is what I always tell my patient. We'll give it either way, but the problem is about the result. It's very difficult to comment.
But once you have operated and results have not come, they will burn you.
Sort of right from day one, you see the patient, just keep telling it's poor, let him go somewhere else. You can let it be. But right from day one, I tell them the chance is 60%, 70%, 60%.
Very difficult situation.
So that at the end, because it's been 4 times, I have had it either way, 2 times either way. So I'm really skeptical about this subgroup of patients. Stiff with a massive cuff is really bad.
Right.
Great discussion.
And
So I think it's the right message for us to end
But it was
the session.
Good discussion. Hope.
sir, how frequently do you frozen shoulders actually?
Release?
How frequently do you operate frozen shoulders? Like, how frequently do you need to operate them?
Operate frozen. This is a very good question. So it should be less than 5 to 10% of all the patients that you see.
5%.
Once or twice in a year is the maximum I operate upon a frozen shoulder. Most of the patients are very compliant. They're very happy if the pain goes off. Stiffness is the last thing on their mind. Most of the patients, let's say silver stiffness.
See, Siddharth, I tell you, the capsular release is a surgery that patient should come and ask you to do.
Yes, that is what I mean.
And that will be the patient who will be the most happy patient. You just advise them that this is one of the technique, that too after 5 to 6 months of the conservative therapy, right?
That too when the pain has resolved, pain has gone.
Pain has gone. See, if the pain has gone, he will never ask you surgery. If the patient is still painful, he will ask you for the surgery. But it should always be the patient who should ask you for the surgery. Now I cannot bear it. Night pains or something.
Yeah. That is the right message. They should not put their hand into a frozen shoulder surgery. That is one of those things that you lose your confidence on.
Yeah, because sometimes even you won't be even go inside the joint also. And what Prathmesh has told, extra-articular release, it is one of the most difficult thing to do. It was looking so easy in his hands, but actually it is not.
It is very difficult to actually go ahead. And search for a biceps itself is difficult.
Right.
I think we can, Dr.
We
Prathmesh.
can call
Yes,
it a
sir.
day.
Sure.
Okay.
Thank you all the esteemed panelists and all the participants for attending this webinar. And I thank Biotek for giving us this platform. And we hope that these kind of academic events will continue from the side. Thank you. Thank you.